a lot of policies and guidelines to coordinate this issue in order to provide the best quality of service toward our patients. Our topic for today will be presented by Dr. Mohammed Mazhar. Dr. Mazhar is currently working as a clinical coordinator and drug information specialist at King Khalid Eye Specialist Hospital. He got his degree in Doctor of Pharmacy on 2010 from University of Karachi, and on 2020 he got the Diploma of Pharmacy Leadership Academy from the American Society of Health System Pharmacist Foundation. He also initiated the Antimicrobial Stewardship Program at KKISH and member of the IRB and Pharmacy Therapeutic Committee. Let's welcome Dr. Mazhar.
Assalamu alaikum and good afternoon, everyone. Again, I welcome you all on this the grand rounds, and we are very from the pharmacy, since I'm representing the pharmacy department, so I'm very excited that we will be part of this grand round with all our other healthcare providers. So as Dr. Abdullah mentioned in the introduction, the topic for today is medication safety in ophthalmology practice. So I have no relevant conflict of interest to disclose. For this presentation, I will be talking about the scope of medication safety, both in general and in ophthalmology also. I will be talking about some literature review on medication errors in ophthalmology, some recommendation and point of view from the SIBAHI and the JCI for medication safety. I will be sharing a report from ISMP, and I will discuss in detail what is ISMP and their recent report. Also, we will learn some lessons from high reliability organizations and how we as Ophthalmic Institute or any other healthcare institute can take inspiration from high reliability organizations. And towards the end of this presentation, we will talk about the implementation of medication safety at ophthalmic institutes with some recommendations and obstacles. So, inshallah, we will start now with the introduction of the medication safety. So this presentation will assist you in, especially in applying the medication safety practices in ophthalmology setting. Since we are a specialized setting, so it has to be a customized and more specialized program. And we will identify some areas improvement and also some knowing some recommendations from international agencies and societies. Now, one thing which I specifically mentioned in this slide is that medication safety is a broad term, and it is not limited to medication errors. So it has multiple areas and aspects which we will explore during this in the next few minutes. So the scope of medication safety, like who are the people who should be part of this medication safety program? Is it responsibility of one individual or it's a collective responsibility? We will see through this in few slides. So as per the American Society of Health System Pharmacists, they give a statement on the role of medication safety leader. Sorry. Yes. So the ASHP, they define this medication safety as the scope as a comprehensive scope. So they are not limiting this to a specific group of people or only to pharmacists or to only specific specialty. So they are saying if the scope is comprehensive, intended to span the entire medication use process as practiced by every participant discipline across the entire healthcare organization. So it's a very broad term, and in the next slide, you will see that starting from the entry point in the hospital, even before that, the medication use until the end, the patient medication is given to the patient, and even the outcome, each and every step, the medication safety principles are applied. They further mentioned that medication safety leaders must collaborate with all type of healthcare professionals, support staff, management, and consider all components of the medication use process in all setting of healthcare. And it could be inpatient clinic, community pharmacies, drug distribution centers in order to improve the medication safety. So now, as I mentioned, medication use process. So what is actually the medication use process? Since they are saying that the medication safety is applied throughout the medication use process. In this slide, you can see here, as it is defined by the Joint Commission International, they say that the safe, effective medication use involves a multidisciplinary, coordinated effort of healthcare practitioners. And the medication management process includes, if you see these boxes, starting from selecting, then procuring means purchasing or getting the medication, then storing the medication, and then prescribing. Prescribing obviously means physicians or ophthalmologists. Then preparing, dispensing, administering, the nursing, documenting it's everybody, all healthcare providers, reducing errors and monitoring. So it is a collective effort of all the healthcare providers, not just limited to one profession. Further, the Joint Commission, they mentioned in their standards, they have a set of standards, and they mentioned that the orientation of medical students and trainee includes at least the hospital quality patient safety program, infection control, and the medication safety program. So it is one of the standard that at the entry point, the medical students and the trainee must be oriented with the medication safety program of the hospital. Let's talk about some literature review on the medication safety in ophthalmology. So I did some literature search if I can find some prescribing errors in ophthalmology or in eye hospitals or ophthalmic setting. Uh, Although there is not much literature available, which is actually one of the area which we collectively should be focusing, and I will discuss in future slides. But from the available literature, I just pick some important points from these articles, that what are the areas or the medication errors which usually happen in ophthalmic settings. So among them, the top were the wrong eye drop installation is one of the most common medication error all around the world in different literature. For example, the Tobradex and Tobrex sound alike names. Ophthalmic medications, which additionally have non-ophthalmic forms such as acyclovir, Zovirax. It has ophthalmic preparation. Sorry, it has the oral suspension. It has injection. It has ointments with the same name. So this causes some confusion and medication error. Also, the literature suggests that those who have available, which have available both as eye drops and ointments such as ciprofloxacin, this causes errors. Prescription with wrong eye, this is also one of the error in ophthalmic settings. Also, pregnancy and lactation, patients who are on this particular medication, and then with development of this lactation or pregnancy status, the regimen has to be changed. This is also one of the medication near misses or medication errors found in ophthalmic patients. And along with that, there is also some dispensing and administration errors from the other healthcare providers. So these are some of the possible errors which can happen in the ophthalmic settings. I found this paper from the American Academy of Ophthalmology, where they discuss about the minimizing medication errors, and they define some of the areas where there is a possibility that error can happen in an ophthalmic setting. First, in their paper, they define medication error as any preventable event that may cause or lead to inappropriate medication use, patient harm while the medication is in control of the healthcare professional, patient or consumer. This is a very well-renowned definition of medication error. Further, they elaborate this, that at what level, this question arises, that what are the points where these errors can happen. So they further define that such events may be related to professional practice, even healthcare products, which means that there could be a drug defect. It could be a procedure and systems can cause these errors. It can be including prescribing errors or communication or product labeling issue, or it could be a packaging error. It could be a compounding error, some contamination or dispensing distribution. So it can happen at any level. So it's regardless. So we should be considering it as a broader term. So it can happen, the medication error can happen at any point. Further, they they defined set of recommendations, and and it was a very comprehensive recommendation, because the American Academy of Ophthalmology, They collaborated with the American Society of Ophthalmic Registered Nurses and the American Association of Eye and Ear Hospitals. And they have mentioned in this paper that 700 medico-legal cases in US in ophthalmology. The medication error were found to be the third most frequent complaint from all those 700 medical legal cases. So this is how significant these errors can be. At the end of their recommendation, they have mentioned some of the points at which can contribute or which can lead to medication errors. So I'll read few of them, not all of them, because it's a long list. For example, unavailable patient information. Patient allergies are not mentioned in the profile. So while as a prescriber, if you are ordering a medication and you are not aware the patient is penicillin allergic, and yet you prescribe any penicillin drug, this can lead to patient allergy. So it means that you don't have enough information, and yet which lead to this error. Unavailable drug information, the right the resources were not available to get the actual dose and side effects, or the compromised dose. Patient has renal impairment, so how you will reduce the dose. So if the information is not available, that can also lead to harm. Miscommunication, like sound alike. Nowadays in hospitals, we talk a lot about these look-alike drugs, sound-alike drugs. Drug device accusation, which means there is lack of standardization in there are no proper marking and measuring the drug in, and also some surgical instrument can happen also, or if proper validation is not there. Environmental stress is also one of the mentioned, which American Academy of Ophthalmology have mentioned, that lightning, heat, noise, these factors can also distract and can lead to error. Lack of awareness of error-prone situation, and yes, limited patient education. The patient may take the medication in a wrong way, that could also lead to harm. And at the end, improper system of identifying, reporting, and analyzing, correcting the errors. So overall, this is what they have defined can lead to medication errors. Now, in this slide, I'm going to share with you some information, a very useful information, which could be an eye opener for ophthalmic setting. There is an institute, we call it the Institute of Safe Medication Practices. Now they are a non-profit organization devoted entirely to preventing the medication error, and they are actually considered as gold standard. And to that extent that even the Joint Commission International, they also refer to ISMP. And Dr. Abdullah also informed me that even the Saudi FDA, they work in collaboration with ISMP, and they share the data of the medication errors in order to constitute a global data. Recently in 2020, 2021, the ISMP, they constituted best practices, which they call it the targeted medication safety best practices for hospitals. Now this best practices, it's a document which has 16 list of 16 best practices, and the purpose is to identify, inspire, and mobilize widespread adoption of consensus-based best practices for specific medication safety issues. Now, let me tell you that how they collect. They actually collect the data of the number of medication errors reported globally, and they pick up the top most reported errors, and they compile it in the form of document and share it with the healthcare institutes, so that we can define or review our practices. So from this 16 best practices, now there must be a question in all of us minds that we are eye hospitals, so are these practices applicable to us also? Because this is generally defined for all the hospitals, generally for all the healthcare institutes. So from these 16 best practices, I was very surprised to know that out of these 16, 13 best practices are directly related to ophthalmology practice. So apparently there is no discount for any ophthalmic institute. We can say that as a general hospital, and the departments, ophthalmic departments, which are within general hospitals, for them, all the 16 best practices are applicable. In the next slide, I will show you how these recommendations, I'm not going to read them all, but I will just pick up few for your attention. For example, the first one, which is for a specific eye hospital, this may not be available, but I understand that in general hospital, for sure, this vincristine is available. So there could be a possible error, uh, and we should be very vigilant. Now, the second one is methotrexate dosing related errors. Now, this is global. Again, this is not related to ophthalmic. This is not related. This is global for all the hospitals, and we see how much methotrexate is consumed in an eye hospital, especially in uveitis patients or autoimmune disease. The third one is updated patient weight. So they have recommendation that at every visit the patient's weight should be updated, and the order should not be processed unless there is no patient weight, especially in the ER and the inpatient. Uh, and we can name the list. They talk about the neuromuscular blocking agents. They should be segregated. They talk about infusion pumps. They talk about standardized protocols. For example, the use of antidotes or reversal agents. They also talk about the sterile water, which is actually hypotonic. Normal saline is a isotonic solution with the blood. It can be given, but sterile water, plain sterile water, is a hypotonic solution. So if it's given in large number, it could lead to some medication error and harm to the patient. Sterile preparations. So we can just imagine in our ophthalmic practice all these things we do in our routine. Then they talk about the use information about medication safety risk. They also talk about the opioid status. Now, this is very important. They have recently added this. The ICMP recommends that verify and document a patient's opioid status. So if either naive versus tolerant. So if a patient has come to the hospital, eye hospital, and he's for some reason he or she needs a opioid, the ISMP recommends that it should be mentioned that this is the first time this patient is getting the opioid, or this patient is already on opioid from outside the hospital, and also what type of pain, is it acute or chronic, and if this is done, a lot of future complications can be avoided. And lastly, to talk about medication can have been removed from, we use a lot of the automated dispensing cabinet, override functions, and Pixis machines. So that also is one of the concern from the ISMP. So what I want to say is that we as Ophthalmic Institute, we should be equally vigilant as any other general hospital in terms of medication safety. Before I go towards the recommendations of how to develop a medication safety program in any ophthalmic institute, I just want to share one. It's a relatively new concept which is being applied and being thought of about the hospital. It's called high reliability organizations. Uh, Now, this one, I found a paper from the US Agency of Healthcare Research and Quality. They have a patient safety network. Uh, According to them, the high reliability organization operate in complex, high hazard domains for extended periods without serious accidents or catastrophic failures. And the concept of high reliability is attractive for healthcare due to the complexity of operation. We can imagine that we as healthcare providers in a hospital, all the time we are taking precautions before the surgery, at the time of giving medication, dispensing medications. So how we can get inspired from high reliability organizations, we will see in the next slide. So what are the characteristics of high reliability organizations? So we call it HRO, or high reliability organization. They cultivate resilience by relentlessly prioritizing safety over the performance pressure. Now, the most common example of the air traffic control. I mean, we can see the most busiest airports in the world. They have flights landing after every 30 seconds, 40 seconds, and they have a very good safety margin. So now the healthcare agencies, now they are getting inspired from these high reliability organization, and they want to implement this thing in hospitals. And very soon in future, I think we will be seeing more action from the health authorities. The HRO are keenly aware that safety is an emergent rather than a static property. And HRO work to create an environment in which potentially problems are anticipated. So it's like a proactive thinking. They don't wait for the catastrophe to happen, but they, even with small Near misses, they take it seriously and they work on it and they collectively find solutions. So generally, what are the 5 characteristics which these HROs or high reliability organizations have, which we can adapt? Uh, First one is the preoccupation with failure, which means that the new threats, they are the HRO or the high reliability organizations, they are aware that the new threats emerge from situations that no one imagined could occur, uh, which means that the near misses. So they don't ignore the near misses or small errors. Uh, Secondly, the reluctance to simplify. So they resist in simplifying their understanding to work process, which means that they are detail oriented. If a process from A to Z, they need to know each and every step so that in case there is something, an error or some catastrophe happen, they can analyze it where it went wrong. Sensitivity operation, uh, simply like situation awareness. So if we are working in one department, so we are aware that what are the neighboring department, or if there is any procedure going on in the hospital, what are the stakeholders involved in this, so they can work as a collective. They don't work in individual capacity, they work as collective. The fourth one is the deference of expertise. uh, this actually means that they encourage everybody to speak up against any potential safety problem. So there is no they don't discourage them, or they encourage them to speak up, and sometimes they also give incentives to those people who speak up about the potential safety problems. And lastly, commitment to resilience, which means that in high reliability organization, they assume that the system is at risk of failure. So continuously they do tests, they do uh, they call it random drills to test their security systems, to test their different safety systems, and make sure that there is no potential catastrophe happens. So these are one of the 5 characteristics, and we as healthcare providers should also take inspiration from these characteristics and apply it to our practice. Now we move towards the medication safety and ophthalmology institutes. Now it's yes, for sure, it has to be a customized medication safety program. But at the same time, we see that most of the international standards of general hospitals are also applied to ophthalmic hospitals. So there is no, I would say, there is no discount for ophthalmic institutes also, that we may think that we are eye hospital, so we may not be taking some extra precaution. No, it should be same for all the healthcare institutes. We need proper staff training to practice medication safety, and it's of course it's a multidisciplinary approach. Now this is it's a model. We can have a modified model, but it's a model about ophthalmic medication safety program in ophthalmic institute. So it should include, obviously it should be led by a medication safety officer who is expert of all these attributes, and physician means ophthalmologist, anesthesiologist, internal medicine, family medicine, everybody should be part of this. Pharmacist, quality management team, the nursing, and all the allied healthcare staff, information technology also. So they should collaboratively, they should make a medication safety program. Uh, so what could be some strategies that we can apply for ensuring the medication safety in an ophthalmic institute? Uh, I've named a few of them. As you can see, evidence-based medicine, safety and effective medication, procurement, storing, formulary restriction, staff education, medication error reporting, adverse. So actually, these are all the activities which are done in medication safety program. So I will give some recommendations in the next few slides, and then we will move towards the final conclusion of this presentation. First, uh, strategy could be evidence-based medicine or evidence-based medication. We use some certain guidelines which are evidence-based. And ophthalmic disease treatment guideline, to ensuring the maximum adherence to these guidelines, for example, microbial keratitis, uveitis, so that we have a standardized way. And there are many, if you go deep into this topic, it can lead to microbial resistance and all these things. So if we have an evidence-based practice, we can have a safe medication use. Secondly, there should be the selecting safe and effective medication. This is basically, again, a comprehensive, a combined role. PNT committee is the lead role in this task, which means that there should be pertinent or appropriate scientific evidence is referred before adding any drug to the formulary, especially in Ophthalmic Institute, where we understand that we have off-label drug use, we have non-formulary drug use. Uh, uh, Probably there may not be enough literature available, uh, but whatever the decision should be made on evidence-based, considering the safety, efficacy, the risk versus benefit, and also the post-marketing data. So if a drug is approved, there should be the review the utilization of drug for potential safety concerns. So for the next 5-6 months, we should see that how the drug is working, is it causing some side effects, or how is the efficacy, and also the antimicrobial stewardship program. We in KKH we also have a stewardship program in the hospital where we monitor the use of medications, especially the antibiotics in the hospital. So this could be one strategy. Another strategy could be the procurement and storing. Procurement means borrowing it or purchasing it, the medication, and bringing to the hospital. Now, we as healthcare providers, regardless as physician, nurses, ophthalmologists, pharmacy, we should be aware of the how in our institute we can approach for non-formulary medication, how we can approach for off-label use of medication, and how we can approach for investigational drug. All these medication, which means that they are not a regular use medication, but they have slight use for specific patient. It could be for specific indication. So important precautions need to be taken. We cannot just use off-label use without monitoring. Similarly, we cannot use non-formulary medication in an institute without proper taking safety measures. Investigational drugs, again, it has to be, if it's a clinical trial, proper monitoring and supervision should be done for these drugs. Only that way we can ensure the medication safety. In addition to that, formulary restriction and pre-authorization. You must have heard about the highlight medications, the look-alike, sound-alike medications, medications which cause risk of falls. And also, through this formulary restriction, we can limit the use of medication to specific indications. For example, anti-VEGF, Eylea, Lucentis, these drugs, it can be limited to the retina specialists or consultants only. So if anybody other than them prescribes, the order will not go through. This is how we can ensure that the drug is being used by expert of that specialty. In addition to that, the Sebahi standards, they also specify further that these highlight medications are those which, if used with slight error, can cause potential harm to the patient. Look-alike, sound-alike, drugs which they have a similar appearance and can cause dispensing errors, and medication. And lastly, so according to Sebahi, these three are the essential safety requirement, which means that any institute, Ophthalmic Institute or any institute which does not meet any one of these criteria, they will not meet the Sebahi standards at all. So they are very strict on these things. In addition to that, we can also have a medication error reporting system in the hospital. This is a very, very important part. So there should be a robust reporting system, and the reporting system should be easy and accessible to all healthcare providers. This is one of the, I'm sure our colleagues attending this presentation from other hospitals, they will also agree with me that there's always a discussion about how to make this reporting system more easy, more accessible. Therefore, in our institute, we have a system, we call it Salama. We have named the system, and it's very easily accessible to all the healthcare providers, and they can report any medication error through this reporting system. In addition to that, there should be a proper feedback. Person who's reporting that medication error, the quality management or the people who are dealing with this incident report, they should give proper feedback that what action has been taken, so that they are encouraged for future also to report. So another very important, actually, this is one area which, as Ophthalmic Institute, we should be very vigilant. Adverse drug reaction. Now, since we are as a specialized hospital, the drugs which we are using here are mostly ophthalmic. So the other institutes, the general institutes, the Saudi FDA, they have some high expectations from us that we give a proper and timely feedback about the drugs which we are using in the hospital. So ADR, as we know, that is defined as any noxious, unintended, or undesirable, unexpected response to a drug that can occur at doses in humans for prophylaxis, diagnosis, therapy. So it can happen, the harmful effect can happen even at normal doses. So we as healthcare providers in any institute should we should have an awareness of our institute's adverse drug event reporting process. And there should be a continuous review of this adverse drug event, and it should be again shared with our colleagues also, so that there should be a visible action going on, reporting feedback, and obviously improvement also. In KKISH, in our hospital, we have established this electronic reporting system with the help of our IT department. So the healthcare provider can directly report the adverse drug event of a suspected drug through electronic patient record. And within the electronic patient record, they don't have to go out of the system or fill a specific form. Within the patient profile, they can simply fill the adverse drug event form and they can submit and it will be reported. So it's a very user-friendly. So the report can be retrieved with all the information of the ADE, and the reports then we share with the Saudi FDA. So this is how we can also develop this adverse drug reaction reporting in our institutes. Product defect complaints. Now this is again where you must have experience in your practice that some drugs, uh, when they have a different brand, they act differently. They have the efficacy is different in different patients. Or some medications, they have a better efficacy, but when we use the same chemical of different brand, may have a different efficacy, or vice versa. So these things are come under the domain of product defect complaint. Again, the Saudi FDA, they have high expectations from ophthalmic institutes to give feedback on ophthalmic medications. And because then only based on our feedback they can take action to recall a drug product or to improve the quality of different eye related drugs. So we as all healthcare providers should be vigilant in assessing the quality of drugs. So under efficacious drug can lead to patient harm. So this is also one way of patient harm. Physical defect in the drug packaging. This is also very important. I mean, the cap can be broken. If it's a glass bottle, so there could be some deformity in the glass. That is also needs to be reported. And patient's opinion should be considered when assessing the quality of drug. So if the patient say that he's taking the drug and the pain is not relieving or the inflammation is not relieving, so we should at least review the medication quality also. This picture is it's from the Saudi FDA website. As you can see, that we can report the product quality, adverse drug reaction, cosmetic side effects, and even the medication error through their web portal in the Saudi FDA. And since they are the relevant authority, then they have the authority to take action against that specific drug. Now, since we are moving towards the end, so the last few strategies we can apply in ensuring the medication safety is patient education. This is very important, especially the medication adherence measurement. Recently, we did a study in our hospital for in uveitis patients, and we did interviews with the patients to measure their adherence with the uveitis medication, and we had some very the results will be very helpful for us to improve the patient adherence, medication adherence in the patient. So this should not be ignored. We can take help from the pharmacy department, health education department, to make a multidisciplinary team and have a proper patient education and follow-ups. And the staff education, we discussed this before also, that the medication safety program, as per the JCI, they have made this mandatory that all the staff should go through this orientation for the medication safety program. In the end, about the last strategy we should apply is the information technology utilization. In KKISH, we have been very lucky and fortunate that we have a very active IT department, and they have helped us creating many reports, and we can retrieve data and analyze the data and apply this to our medication safety program. So this is also very important that the data, relevant data, should be retrievable through the electronic patient health record. Now, what could be the possible obstacles? Well, I've just mentioned some common obstacle like limited scientific data available. So we can have a designated research group. This is my recommendation, that we can have a designated research group for medication safety related research. It could be in the kingdom or globally. We can be a part of a group. So obviously there is we are lacking some scientific literature about the medication safety in ophthalmology. So we can have think about this. Also, the in compromising the treatment outcome, if there is a compromised treatment outcome, so we should use the to measure the adherence of patient and patient follow-up, regular patient follow-up. That could help us to find the reasons if there is any treatment failure. Also, under reporting of adverse event, this is one of the main obstacle. And to overcome the obstacle, we can do some general awareness program for healthcare providers, and also we can make electronic reporting to facilitate our healthcare providers. And we in KCASH, we have done this. We have made this adverse event reporting very easy, and they can easily, the healthcare providers, within 5 to 6 seconds, they can report the adverse drug event without going out of the patient's profile or leaving their work. They can simply report the. So it has to be made simple and effective. Now, towards the end, I will summarize my discussion. So, encouraging multidisciplinary collaboration to ensure the best practices for any medication safety program. We should be utilize information technology to enhance the medication safety through surveillance, outcome reporting, and development of clinical decision support tool. Build medication safety information sharing program between ophthalmic institute. Again, this is one thing would be very important, that the ophthalmic institutes in the kingdom or globally should share the safety information, what kind of errors are happening, what improvement measures can be are taking to overcome any deficiencies. That would be helpful. Also, to patient education program should be enhanced. We should go towards more telecommunication and telepharmacy or telemedicine. Strict medication reconciliation is very important, that we see that at every transition of care the medication is being reviewed. There should be effective tools to quantify the medication safety. Whatever we do, it should be quantifiable, it should be measurable. If it's not measurable, we will not be able to improve. So whatever systems are developed should be measurable. And at the end, medication safety is a broad term, and I repeat, it's not limited to medication errors only. It's a set of combined activities with stakeholders, starting from ophthalmologists, medicine, anesthesiologists, nursing, pharmacists, all allied healthcare providers, labs. So it's a combined effort. And even one chain is from this chain, if one part is missing, the circle will not be complete of the medication error program. So thank you very much for your time. And I will be very happy if you have any question, I can respond to it. Thank you very much. Yes, Dr. Abdullah.
Thank you, Dr. Mazhar, for the formal presentation. Time now for a question. Okay, Dr. Muhammad, there's a question said that what is the difference between adverse drug reaction and adverse drug event?
Yes, actually, these terms are slightly different, because adverse drug event is a broader term which comprise of adverse drug reactions also and medication errors also. Whereas the adverse drug reaction is a specific reaction because of a drug that causes patient harm. So sometimes these terms are interchangeably used, but to be specific, the adverse drug event is a broader term, and adverse drug reaction is within the adverse drug event, which includes all the medication error plus the adverse drug reaction comprise of this adverse drug event.
Okay. Second question, what are the main obstacles that you encountered to adapt the medication safety culture at KCASH?
Yes, actually, the obstacles, when we were developing this program in KKISH, um, it all started with the engagement of our leadership in the hospital. So that motivated us to spread this and develop this program. So there was also we were the first hospital in Saudi Arabia to have this basic medication safety course, and it was made mandatory for all the healthcare providers. That was very helpful. Also, we did a lot of staff education. We did, we shared information about the medication errors and the ADR with our staff and the interventions. So this actually created, established a culture, and also we one important thing which was about the reporting. One of the obstacle was the reporting, that how to do the reporting. That was overcome by through electronic reporting system, which was the IT department helped us in that. So that has made our work very easy, and the healthcare providers can easily report electronically. So these were some of the obstacles which we noticed. But this process overall, it needs continuous reminders, continuous education. So we cannot just do one-time effort and stop, but it needs a continuous improvement. Yeah.
Um, Thank you, Doctor. Seems we
Thank you
don't
very much.
have other question. I think we come to conclude our session for today. Thank you very much.